we have Dr. Kevin Wood. He is board certified by the American Board of Internal Medicine with a subspecialty board of Hematology and a subspecialty in the Board of Medical Oncology. He received his education at the University of Kansas, completed his fellowship at the University of Chicago, and his residency at New York Presbyterian Hospital in New York. So I'm handing it over to Dr. Wood.
Thank you. Hey, everybody. I'm glad everyone can make it. I'm sorry I can't see any of you, but it's really a pleasure to be here. Rochelle, you can hear me and see everything okay?
Yes.
Okay, perfect. So as she mentioned, I'm going to be talking about cancer screening today. I'm one of the medical oncologists over at LaCal. I primarily see head and neck cancer and GI cancers, but today we'll kind of be talking about cancer screening in general. I thought to make it a little bit more interesting, we could do kind of a top 10 list, just to hopefully help you guys remember things and recall things at a later date. So top things to know about cancer screening. So point number one, see if I can get this working here. Cancer, as many of you probably know, is unfortunately one of the leading causes of deaths in the United States. Indeed, cancer is second only to heart disease as a cause of death in the United States. You see kind of the figure over here of the most common causes, heart disease, cancer, and this is from a couple years ago, but COVID-19 in 2020 being the primary causes. In the US in 2020, there were 1.8 million new cancer cases and 600,000 cancer deaths. So anything we could do to lower these numbers would have a considerable impact, obviously. In the world in 2020, it was almost 10 times that. So 18.1 million new cancer cases, and estimates for 20 years from now in 2040 estimate probably around 30 million new cancer cases globally will be diagnosed each year. And a lot of that speaks to the fact that we're getting better at medicine, right? So we're doing a better job at treating heart disease and diabetes, and patients are living longer and unfortunately have a propensity as they get older to develop cancer at some point. So increasingly, cancer screening is becoming important. Even know that now, though, in 2023, the lifetime risk of developing cancer is actually quite high. So the figure on the left is looking at males. The figure on the left or on the right is looking at females, but this is the risk of developing cancer at some point in your life. For males, it's 1 in 2 at any site, meaning at any spot in the body. And for females, the risk is 1 in 3. You'll notice for males here on the left, prostate, lung, and colon are kind of the 3 most common cancers that are seen. For females, breast, lung, and colon are the 3 most common. And we'll kind of focus in on all 4 of these today in regards to screening for all of them. It's not all bad news, though. So despite those kind of scary statistics, point number 2 is that death rates from cancer have decreased by 27% in the last 20 years. So we're doing a much better job at catching these cancers early and doing a much better job at treating them when they do develop. So why are cancer death rates declining? You know, I think there's kind of 3 primary reasons that I think of for why the rates are going down and we're doing better. So one is screening, which is what we're talking about today, but screening is incredibly important and everyone should be doing this with their primary care doctor. Just one example, for instance, with annual mammograms and for breast cancer, it's decreased the mortality rate or chance of death by 40% for women with breast cancer, which is a huge number. We've saved so many lives with mammograms. It should really be emphasized. You know, the other thing that's really helped us is we've made huge advancements in patients once they've been diagnosed with cancer. So in our treatment techniques, just one example, for instance, is something called immunotherapy. So immunotherapy, you might have seen the drug commercials for drugs like Keytruda or nivolumab, because they work very well in a lot of different cancer types. But immunotherapy is very different from something like chemotherapy. So chemo, I kind of think of as like poison. It goes in there and kills the cancer cells, but also kills your healthy cells, and you can get a lot of side effects. Immunotherapy is very different. So what it's actually doing is it's activating your own immune system to attack the cancer. And so your body's kind of doing the work. And so the side effects in some cases are less and different than with chemotherapy. But it's really made some huge advancements and really revolutionized cancer care and has led to these death rates dropping for sure. Finally, it's patients and the general population. So I think everyone's doing a better job at recognizing what's bad behavior and avoiding that bad behavior. So for instance, smoking, we know tobacco is bad, and so the rates have dropped considerably. And another example would be obesity and diabetes and dealing with blood sugars and exercising. All that has a huge impact on lowering the risk and incidence of cancer developing in the first place. I'd like to really focus in on tobacco just because there's such a huge link between tobacco abuse and the development of cancer, and the rates still remain scarily high. So this figure over here is looking at rates of tobacco abuse in adults in the United States, beginning back in 1994 and then going to 2018. And you'll notice the number has improved considerably, though still remains quite high. What I was a little shocked by was in 1954, for instance, the rate was almost at 50% of US adults were smoking, which is a scary number. So while these numbers are definitely improving, there's still 34 million Americans that are smoking. And we know there's a clear association between smoking and lung cancer. Smoking leads to 85 to 90% of the lung cancers that are diagnosed. So this number remains very scary. And anything we can do to improve this number will lead to improved outcomes and patients living longer and living better lives, cancer-free and without COPD. So point number 3, the person kind of spearheading all this cancer screening is the primary care doctor. And so good communication with your primary care doctor is really vital to ensuring you're staying up to date with all your healthcare maintenance stuff. The way I think about the primary care doctor, they're kind of like the quarterback in your healthcare, right? So there's a lot of specialists out there that can deal with very specific problems. However, you need someone that can kind of look at the whole body and kind of take a more holistic approach and making sure you're getting all your immunizations and getting all your screening done and doing all the appropriate blood work. And the primary care doctors are really the ones to do that. I'd like to kind of brag about our program here at Valley. We have a really wonderful primary care team who's able to get patients to the right people at the right time and get all the screening done. But all that I've met are just very thoughtful and very thorough. And we have a really wonderful program here. So if you do not have a primary care doctor, now is definitely the time to get one. Everyone should have one and be seeing them at least once a year. So point number 4, and I started kind of talking about this a few slides back, but there are a few types of cancers that lead to the vast majority of cancer deaths. And because these are the ones we really want to focus in on when we're thinking about cancer screening, because these are the ones we want to prevent. So here's a slide of the most common causes of cancer-related death in the US. So the most common types of cancers that are leading to the patient ultimately dying or passing because of the cancer. If you remember a few slides back, the most common cancers in males and females were actually prostate and breast cancer. But the one that is leading to the most deaths is actually lung cancer. So this is by far the more deadly of the cancers here. So even though the chance of developing this is a little bit lower, the death rates are significantly higher. Number 2 is colon and rectal cancer. And we're going to talk quite a bit about colonoscopies today and why they're important, but it is one of the leading causes of cancer-related death in the United States. I'm going to briefly talk about pancreas cancer on the next slide. It's unfortunately a deadly cancer, and we, at this point, do not have a great screening method for the general population. So we'll talk briefly about it, but unfortunately, there's no kind of generalized screening method available right now. The other 2 I wanted to focus in on our female breast cancer with the mammogram, and then prostate cancer is another common cause of cancer-related death that we're going to finish things off with. So pancreatic cancer, I think it's worth mentioning just because the chance of death is so high from this disease. It can be a scary disease. And I think this figure kind of is very telling. So on the top here, you see the diagnoses of different cancer types for males and then females here on the right. And you'll notice the chance of developing pancreas cancer is actually quite low. It's kind of here at the bottom of the list. Below here, this figure is looking at the estimated number of deaths from each cancer type. And you'll see that pancreas cancer for both males and females really jumped up. We've gotten better at fighting this disease, but unfortunately, it's still an aggressive disease. And as of this point, we don't have a great method for screening the general population. For patients that are considered very high risk for developing pancreatic cancer, so people with a very strong family history and different types of genetic conditions, we sometimes use endoscopic ultrasounds and MRIs at specialized institutions to confirm and do screening to make sure pancreatic cancer isn't developing. But for most patients, we are not doing this as of 2023. So what screening methods do we have for the other cancer types? So I wanted to start with kind of the most deadly of the cancers, and the most common one, which is lung cancer. Point number 5, low dose CAT scans of the chest are a promising screening modality for lung cancer. So looking at lung cancer and preventing lung cancer from developing, I kind of already made this point, but I think it's worth coming back to. Stopping smoking by and far, rather than screening, remains the strongest way to reduce lung cancer. So if you want to save someone's life and they are smoking, telling them to stop is the best thing you can do for them. And if you are smoking, you should stop. It's a tough habit to stop, though, and it's very addictive. So if you are unable to stop, considering doing a low dose CAT scan of the chest is a very reasonable option to catch cancer early if it does start to develop. So these CAT scans should be done once a year. And the studies have shown that they can actually reduce the chance of dying from lung cancer by around 20%. So they're able to catch cancers early. The CAT scans use a much lower dose of radiation than some of the other CAT scans that are used, and much lower doses that were used 20 or 30 years ago. They also don't require contrast, which some patients hate. That's what they have to give you IV, the liquid, or you have to swallow this kind of nasty solution. It can cause a lot of diarrhea and ickiness. Unfortunately, you do not need that with this. A lot of my patients ask about chest x-rays. They are not helpful in the situation for lung cancer screening. They're not sensitive enough to pick up small things like a growing lung cancer. So I would not recommend chest x-rays for lung cancer screening. It's really only a CAT scan for those at high risk. This is just an example of what we're seeing when we do pick up a lung cancer. So just to orient you a little bit, this is a CAT scan that was done on a patient. White is bone. So they're laying down. This is their back right here, and you see their spinal bone right here. This is the white. Their ribs are coming across. So all the white is bone, and their heart's right here in the middle. Black is air. So this is the right lung over here, and this is the left lung over here. And then this spot here, this white spot, which clearly is asymmetrical and shouldn't be here. This is the suspicious spot that is likely cancer that we are able to catch early. So what are some of the downsides to lung cancer screening? Why would you consider not doing it, even if you do have a strong smoking history? Because I really think it's worth a discussion with your primary care doctor. You know, the first is the risk for false positives. So, you know, what I think CAT scans are great at is picking up abnormalities in the lungs. What they're not great at is telling us 100% what that abnormality is. So typically, if they do see something abnormal, it will typically need to lead to a biopsy being done. And here's an example of that being done over here. So this is, again, a CAT scan of the chest, and they're using the CAT scan to actually guide in this needle from the outside to biopsy that spot in the lung. Whenever you stick in a needle anywhere, and including the lung, it has its own risk. And sometimes after doing this biopsy, we find out that abnormality was nothing. It was just a calcification or a little bit of inflammation. So it can sometimes lead to unnecessary procedures that carry their own risks. The other is radiation exposure. So the dose of radiation is much, much less than was typically used like 20 or 30 years ago, but there's still a risk for radiation exposure. And what they've calculated is that for every 108 lung cancers that are discovered, one major cancer will be induced by radiation. And so this is why we're not doing lung cancer screening in people who have no smoking history, for instance, just because the risks do not outweigh the benefits. It really is only for those patients that are at high risk for developing lung cancer. Finally, the other thing is patient distress. So sometimes these CAT scans, just because they're so sensitive, they can pick up very tiny spots that are actually too small to even biopsy. And you end up not knowing for sure what it is, and you're required just to follow it with another CAT scan 4 or 6 months down the road. And during that 4 to 6 months, you're not sure what it is or what's growing. And for some patients, that can cause a lot of anxiety. So it's really worth a discussion with a primary care doctor, just to make sure you thoroughly kind of understand all the pros and cons of doing lung cancer screening. What are the current recommendations? So eligible patients are those that are between the ages of 50 to 80 years old. They have at least a 20-pack year smoking history, meaning they've smoked a pack a day for 20 years or an equivalent of that. And they're either a current smoker or they quit in the last 15 years. For these patients, we feel like the benefits strongly outweigh the risk, and we would recommend an annual low-dose CT of the chest, getting it done once a year. And you can stop that once you've quit smoking for at least 15 years. And again, emphasize really the thing that's going to help you here is quitting smoking, as hard as that is. So moving down a little bit to everyone's favorite, the colonoscopy. So point number 6, colonoscopy is the gold standard for colon cancer screening. There are other options available though, and I think it's worth a good discussion with your primary care doctor just to make sure you have a firm understanding of all these options and know which one might be right for you. So first, before we kind of delve into the options, let's kind of look at the incidence of, or how well we're doing at actually screening for colon cancer in the first place. So typical guidelines recommend screening for colon cancer should begin at age 50, even so, though some of the guidelines are shifting to start at age 45. What this figure here is looking at is the percentage of patients over the age of 50 in the general population who have some form of colorectal screening done. I focused in on New Jersey here, but in New Jersey, only 66% of adults over the age of 50 are receiving some form of colorectal screening. So there's a large portion of the population is missing this. We're unfortunately getting a flunking grade here, and anything we can do to improve this number could save a significant number of lives. So making colorectal cancer screening easier is a thing we should really be focusing in on. So what are the types of screening for colon cancer that can be considered? I think of 3 main different types. So the first are stool-based tests. So these are basically studies that are done on the stool that you send into the lab, and then you get the results back, but they're non-invasive, no procedure needs to be done. And the 3 types, one is a FIT test, a fecal immunochemical test. The second is fecal occult blood test. And then this third is a stool DNA test. And on the next slide here, I'm going to kind of talk about all 3 of these in detail. So we're going to come back to those in a second. The second option is the endoscopic visualization. And by endoscopy, I mean either a colonoscopy, which is where they put the camera up the rectum and look at the whole colon itself, or something called a sigmoidoscopy, which is used in certain situations. And it's where the sigmoid is basically the very end part of the colon before it turns into the rectum. So a sigmoidoscopy is basically looking at the rectum and the last part of the colon, but there's a large part of the colon that is not being visualized at all. So it's really only used in very specific situations. The last option, and I didn't spend a lot of time talking about this today, but it's radiologic visualization. And by that, I mean basically a CAT scan that's kind of focused, looking specifically inside the colon itself. Again, this is really only used in kind of specific situations. The sensitivity of it is a little bit less than the other options that we're going to delve into. So the chance of missing something is a little bit higher. So oftentimes, if you can, the other options are typically considered first. So let's talk a little bit more about the stool-based tests, just because sometimes I feel like they can get a little confusing. So there's 3 main types. The first 2 are basically looking to detect any microscopic blood in the stool that you're not able to visualize. And microscopic blood is typically the first sign that colon cancer is developing, because these tumors tend to bleed very easily. So the FIT test basically detects blood by looking for antibodies to the hemoglobin or red blood cells themselves. And it detects around 74% of colon cancer. So pretty good sensitivity, but missing around 25% of cases. The fecal occult blood test also tries to detect blood, but it does it in a slightly different way. It basically, if there is any microscopic blood there, it stains blue. So you're able to visualize it. So just looking at blood in a slightly different way. The sensitivity, so the chance of picking up colon cancer is around the same. So depending on the study you look at, around 64 to 80%. The upside to the FIT test, it requires only 1 sample, where with the fecal blood test, you typically have to do multiple samples 3 days in a row. Both of these tests are done annually. The stool DNA test is kind of come into favor here in recent years. And I think this is the one I'm kind of biased to, but if you're going to consider a stool-based test, this is, in my mind, the way to go. The one most people know about is the Cologuard test. There's a lot of commercials with this, but it's the little box that dances around. and you basically send in a stool sample through this box. But it's also looking for blood in the stool, but it adds an additional step as well. So when colon cancer starts to develop, the first thing that happens is mutations occur in the DNA that cause the cancer to develop. So this is looking at the DNA in the stool itself and seeing if any of those common mutations have developed. If you pick it up, it suggests colon cancer might be present or starting to develop. You'll notice the sensitivity is a little bit higher. So the other two, probably around 75% or so of colon cancers are being picked up. Here it's 92%. So the rates certainly go up. And this, depending on the findings, should be done every 1 to 3 years, beginning after the age of 50 or age 45. A couple of things that I think are important to note. So one, if a test is abnormal, a colonoscopy is absolutely required, right? Because this tells you something abnormal is going on. It tells you that likely cancer is present, but it doesn't tell you where in the colon it is, and it doesn't tell you the extent of things. So if you get an abnormal test, you definitely need a colonoscopy. The other is that all the guidelines recommend for patients at high risk for colon cancer. And by that, I mean a patient with a personal or family history of either polyps or colon cancer in a first-degree relative, inflammatory bowel disease like Crohn's disease, for instance, or a genetic condition like Lynch syndrome that predisposes them to colon cancer. For all those patients, they need to skip this and go directly to the colonoscopy, which remains the gold standard. So speaking of, let's kind of delve into colonoscopies here. So both the pros and the cons. So the pro is this by and far remains the gold standard at picking up colon cancers. Even though it's not fun, the sensitivity of this is higher than all the other options available. It's not 100%, so it doesn't pick up every single case. Sometimes things can be missed, but it's in the high 90s. So by and far, it remains the best option. The other thing that makes me think this is kind of the way to go for most patients and the way that I would go is the ability to remove polyps, which the other options do not have. So polyps are basically overgrowths that occur of the tissue inside the colon wall itself. All colon cancers develop from polyps. So the polyp ultimately starts mutating and turns into a colon cancer. Not all polyps will turn into cancer, but all cancers develop from polyps. And so why colonoscopies are, in my mind, kind of the superior method here is the other options do not typically pick up or detect polyps, because oftentimes these are not bleeding and not developing mutations. But with a colonoscopy, if a polyp is seen, you're able to remove it right away before the cancer even develops in the first place. So something to consider, but certainly a pro option. The cons, why would you not consider this? Well, the bowel prep, as everyone knows, it's not fun at all. It's not a great experience, even though we've gotten much better at making it more tolerable for most patients. So that the medications have certainly gotten better. It requires sedation. So patients that are kind of at high risk for sedation and anesthesia, if they have allergies or if they have bad heart disease or bad obesity, this is certainly a risk factor. And then even though the risk is small, whenever you put in a foreign instrument into your body, there's a risk for either perforation or infection. Again, the risks are small, but something to note when you're kind of considering all the options. I'd like to kind of brag about our fast track colonoscopy program here. I hope many of you have heard about it, but I think this is just an amazing program, especially in New Jersey, where our rates of colorectal cancer screening are pretty low. So what is this? So this is a program that basically takes away all the kind of logistical hurdles to getting a colonoscopy done. It makes it much easier for patients. Most of the primary care doctors know about this, so you can ask your doctor when you go to see them. But basically, you call this number here that they will have, and you speak with a nurse navigator over the phone, and they kind of go through your whole history and make sure you might meet all the safety criteria. As long as you do, they schedule the colonoscopy and you go in and get it done. And I think this is so wonderful because it avoids having to schedule a visit with the primary care doctor and then get in to see a gastroenterologist and get all the blood work done. It kind of takes away all the hurdles and you could just easily get this colonoscopy done and then kind of move on with your life. So something to consider if you're considering getting a colonoscopy done, just because it makes the whole process much more seamless. Bottom line, though, with colorectal cancer, and I think with all the types of cancers we're going to be talking about today, is screening is vital. And a discussion with your primary care doctor should definitely be had about which option is best for you. Colonoscopy definitely remains the gold standard, but there's certainly other options available. And it's really sitting down and making sure you kind of understand the pros and cons of each of those options before you make a decision. But some kind of screening should certainly be done. So next up is breast cancer, point number 7. It works really well. So breast cancer screening, as I mentioned before, reduces mortality rates by 40% in women. So mammograms, they detect cancer earlier and they're able to save a lot of lives. Breast cancer, as we know, is unfortunately a common disease. So women have a 1 in 8 chance of developing breast cancer at some point in their life. In 2021, there was around 280,000 new cases diagnosed. And unfortunately, 43,600 women died from breast cancer that year. There are multiple different guidelines that are out there that talk about when you should start doing screening for breast cancer and how frequently you should be getting that done. At Valley, we feel the best kind of guideline or recommendation out there comes from the National Comprehensive Cancer Network, and those are the guidelines we follow. And I think the key line or key recommendation to remember from them is that for average risk women, so this is most of the general population, they recommend an annual mammogram beginning at age 40 and continuing once a year for as long as that woman is in good health. A lot of my patients will ask about MRIs. This is sometimes used in certain high-risk women. So kind of similar to what we talked about prior for high risk, patients with a strong family history of breast cancer, those with a BRCA mutation or some kind of genetic condition that kind of predisposes them to breast cancer. MRIs are certainly being used in that population, but for most average risk women, annual mammogram beginning at age 40 and continuing as long as you're in good health. Next up is prostate cancer. And I think the point here, and I made this a couple of years ago as well, and I think it caught everyone by surprise, but men will be happy to know that digital rectal exams are no longer recommended for prostate cancer screening by most guidelines. So as of 2023, what's actually recommended is something called the prostate-specific antigen lab test, rather than the digital rectal exams as the primary screening mode for prostate cancer. So why is that? So the risk of missing a cancer or the risk of picking up a little bump when you do the digital rectal exams that ultimately ends up being nothing and not cancer is much higher with a digital rectal exam. And so that's why it's really fallen out of favor. What is recommended now is this PSA lab test if you're going to do some kind of screening. So what is that exactly? You know, the way I think about the PSA, it's basically, we call it a tumor marker in oncology, but it's basically a hormone that the cancer cells release into the bloodstream. And you can measure that hormone level. So if that level starts to go up, it suggests that prostate cancer might be developing. The number is a little bit tricky though, because it's non-specific, meaning there are other things that can make the number fluctuate or go up. For instance, any kind of inflammation to the prostate, like a bladder infection or any kind of instrumentation down there can increase this number, and in some patients cause a lot of anxiety when there's actually no cancer. So in my mind, what I tell my patients is we should never panic about a single value. I actually care more about the trend over time. So something to keep in mind when you're getting this test done if you decide to do it. If patients are screened, the recommendations are for average risk patients beginning at age 50. For high risk patients, and high risk in prostate cancer is anyone of African American descent or a family history, specifically a first degree relative with a history of prostate cancer, they should really start screening earlier, typically between the ages of 40 to 45. Number 9, so, cancer's scary. And for a lot of my patients, when we start going through their family history, we realize there's actually a strong propensity for cancer developing. And so we have a really wonderful genetic counseling program here, which I wanted to emphasize. So for patients with a strong family history of cancer, genetic counseling should really be considered. It's important to note that around 5 to 10% of cancers are hereditary. And it's interesting, one of the cancers I see commonly is pancreatic cancer, but the guidelines now say for every patient we see with pancreatic cancer, any patient that has a diagnosis, automatically they should be seeing a genetic counselor, just because the chance of there being a hereditary component in pancreatic cancer is actually a little bit higher, probably around 15%, but everyone is seeing them now here at Valley. Patients we otherwise typically recommend to consider seeing a genetic counselor. So patients with several relatives with cancer, a close relative with cancer at an early age, typically under the age of 50, a relative with more than one cancer, or a relative with a rare or unusual cancer. These guidelines here obviously are a little vague. So I think it's important when you do meet with your primary care doctor to really go through your family history thoroughly, just so they have a good understanding of the incidence of cancer and who developed it and when, because they might end up sending you over to a genetic counselor. The other thing I think it's important to note with genetic counseling is typically the ideal person to get tested is the affected family member. And by that, I mean the person that actually was diagnosed with the cancer. So in these scenarios, for instance, it would be the relatives that had the cancer at an early age, or the relative that had more than one cancer. That would be actually the ideal person to test first, because if they test positive for something, we kind of know what to focus in on you or your other relatives, if that makes sense. Our program here is really strong. We have a few really great genetic counselors who are very thoughtful and very thorough. We're affiliated with the Stang Cancer Prevention Center and also Cornell Medical Centers. It's kind of like you're getting a couple opinions when you're coming to see us, but certain things certainly consider, especially those with a strong family history. And finally, number 10, if you do get diagnosed with cancer, despite all this screening and despite doing everything right, we're here to help. I think that's the final point I wanted to make. But over here at Luckout Pavilion, I'm not sure if you guys have been over here yet or how many of you have. We're going to be right next to the new hospital that's being built and should hopefully be done, I think, this year or next, right across the street. But here at Luckout Pavilion, all of us are kind of subspecialized into different cancer types. As mentioned before, I see the head and neck and GI cancers here, but we really have really wonderful, thoughtful doctors here, and we're here to help you if you need us. With that, I'll finish with a picture of the new hospital that's being built right now, and I'll take any questions, but thank you so much for having me.
Thank you so much, Dr. Wood. You mentioned that smoking is a very high risk for all types of cancer. What research has been done with regards to vaping? Because I know some people, they try to quit smoking, they switch to vaping instead, and they think they're doing something good for themselves.
Yeah, it's a good question. So clearly a lot of the toxins that are in cigarettes are not in vaping. I think what kind of scares me about vaping is we don't have a lot of long-term data yet as to the risks that can be associated with and the risk for cancers. We do know there's a lot of data coming out that in the short term, it can certainly cause inflammations in the lungs and certainly cause pneumonitis and other issues with breathing. And really, in my mind, any kind of inflammation is a risk factor for cancer developing. So while it's certainly probably a healthier option than cigarettes, I don't think it's the right option for most, just because we don't have long-term data. I'm concerned there's still a risk there, if that makes sense.
Yeah, thank you. Thank you. So we have, I guess, more to see. There's another question here. Female, 81 years old.
Mhm.
Does she still need colonoscopies and mammograms?
So it kind of depends on how healthy you are and what other medical conditions you have. For mammograms, the recommendation is as long as you're healthy and you're getting around and living life, it should be continued. But it's really a discussion with your primary care doctor. With the colonoscopies, it's a little bit trickier. And I think it's really sitting down and, again, discussing with a doctor who kind of knows you and your health well. As I mentioned with the colonoscopies, with the risk for anesthesia and actually going through the procedure, it's a little bit higher than with a mammogram. So it's worth a discussion. I do think as you get a little bit older, maybe the benefits of doing something like the Cologuard test, which is much less invasive and doesn't take a lot of time, is a much better option.
Thank you. Is there any studies with regards to radiation coming from ultrasounds, for example, for those people who've gone through IVF and go through so many ultrasounds throughout their pregnancies?
So risk of ultrasounds causing malignancy,
Right.
I think. Yeah. Okay. Yeah. So ultrasounds are very, very safe. There's no risk for radiation exposure with those. MRIs and ultrasounds do not have any radiation exposure. It's the CAT scans and PET scans where the radiation exposure is.
Thank you so much. Let's see. If we don't have any other questions, I'm just waiting to see if anything else comes in. Quick question. You mentioned something about the pancreatic cancer screening and that we don't have that much in way of screening for it. But if somebody's parent, for example, passed away from pancreatic cancer, but didn't have a chance to do any genetic testing, what options are there for the children of that person?
Yeah, great question. So I would still at least talk with your primary care doctor about whether genetic counseling would be appropriate. Just because I think if they, there's a 10 to 15% chance of there being a hereditary component there. And so I think if the affected family member cannot get tested because they passed, it'd be worth a discussion to see if someone else could get tested just for some reassurance. Well, if there was no genetic condition found, I think it's more just continuing to do kind of all the stuff we talked about today, but there's no kind of great method for pancreatic screening at this point. I think if there was a genetic component, it brings up whether we could do something like the ultrasounds where they put a camera down your throat and actually visualize the pancreas, or do MRIs. But for most patients with no genetic condition, it has not been found to be too helpful and can lead to a lot of false positives. So a lot of anxiety about something that ends up being nothing.
Well, thank you so much, Dr. Wood. Your presentation was so comprehensive.